All right, this video, our main focus is going to be treatments for bladder cancer. And there's a few interesting angles to this. So the main focus of this, as discussed, is going to be how we treat bladder cancer, a few different options. And the context is, like any cancer type, there are a lot of different varieties of bladder cancer. The first question is, what depth of metastasis are we looking at here? How far into the bladder has the cancer spread? So these layers of tissues, the very interior here, that's the internal lining. It's called an epithelium. So this would be the interior of the bladder. These other layers, the lamina propria, is a layer of connective tissue. And then you've got two separate layers of muscle. This would be the muscle tissue that's squeezing and contracting when the bladder empties. And in the graphic, the red circles or discs are supposed to represent cancer cells, and we can stage this in two parts. First, has it actually invaded the muscle layer, meaning deeper into the wall of the bladder? So if not, non-muscle invasive. If it has, then it is muscle invasive, and we can give it different rankings at that point based on how far the tumor has actually progressed. Okay, so bladder cancer being relatively common, pretty serious as far as survival rates goes. It's not that any cancer is a great one to have. It's definitely near the bottom of the list. And traditionally, one of the go-to treatments for this muscle-invasive bladder cancer is BCG. And it's very, very interesting. BCG, Bacillus calmette-guerin. Bacillus refers to a type of bacteria. And so what's really, really fascinating is this molecule, BCG, is actually used as a vaccine against tuberculosis because it comes from a bacterium that's somewhat similar, has some overlap in structure to tuberculosis. And what's odd is if you inject this BCG molecule directly inject it into the bladder of someone that has bladder cancer, right? We're trying to make this local and not a systemic response. Somehow, through a mechanism that isn't completely understood, that BCG molecule will stimulate an immune response. So dendritic cells in the bladder, right? These are basically, remember, acting like macrophages for the immune system. They detect the presence of BCG, start displaying the BCG antigen on their surface. And for reasons that, like I said, don't seem to be completely understood, that recruits a bunch of immune cells, most importantly, like T cells, cytotoxic T cells, natural killer cells. And since the BCG gets taken up by those cancer cells, right? This is our cancer cell, and it's taken up some of that BCG molecule. The immune cells that are now attracted to the site, they're showing these immune cells as all these different colored cells surrounding our cancer cell. Because we've locally concentrated that BCG molecule within the bladder, right, it increases the immune system's attack on that cancer. All right, the problem that we're dealing with is there has been shortage of BCG. It's not available, at least in the quantities that it should be. And so patients are having to look to other options. And BCG is also not perfect. And so partly we're looking for a replacement when it's not available, and partly probably a potential adjunct in addition to BCG. All right. Okay, so the process so this company that's developing alternatives to BCG therapy, this is just showing their thought process. They're first separating people by whether they have intermediate or high-risk bladder cancer. There's really no such thing as low-risk bladder cancer, so that's not an option. And then testing a few different possibilities. So if it's high risk, that patient is going to be prioritized to get BCG treatment. And so when we say they start off as BCG naive, it just means no treatment yet, right? Once they are treated with BCG, which is likely if they're high risk because they get a priority to get the drug that's under a shortage, then we decide, okay, are they responsive? And so this is splitting them into BCG responsive versus unresponsive. And from there, we've got a couple options. The new drug that we're going to look at in a bit that's being developed, you can use it on its own, monotherapy, or you can use it in combination with another therapy. And this appears to be a checkpoint inhibitor targeting the PD-1, PD-L1 checkpoint that we've seen in previous videos. And so a lot of this will hopefully tie things together from what we've seen previously. Okay, so the drug in question. This drug, crestimogene grenadenorevec, it's a heck of a name that someone came up with. And the idea behind it is it's sort of interesting because it's not really an immunotherapy, and it's not technically a prophylactic vaccine because we're giving it to people that already have cancer, but it acts very much in the same way that a cancer vaccine does. And so it's effectively like a vaccine, but instead of being used for prevention, it's being used for therapy. The very broad overview is that the medication itself is packaged into a virus. So this little sort of spiky shaped thing is showing you a virus that is used to package some genetic material that we specifically have engineered to preferentially invade cells of the bladder. Right, so once the virus is in the body, remember, viruses can only replicate intracellularly. They have to be inside of a human cell. Once that replication starts happening, we expect a stimulation of the immune system because now the viral proteins and the proteins that we've engineered into that virus are going to be expressed on the tumor cells. Okay, so from there, we hope that the virus continues to replicate and spread, but obviously specificity is the key part of this. We can't have this virus, spreading through other parts of the body. It has to only spread through the tumor cells. And so you've got a two-pronged approach here. Some of the tumor cells are killed by the virus itself, and it also attracts the immune system to come in and join the party so that T cells, cytotoxic T cells, are recognizing those viral antigens on the cancer cell surface, right, amplifying our immune response. So in a little bit more detail. So the idea here is these are our tumor cells, and these guys are our viruses. Now, in order to make this happen, a very specific pathway that has been deranged in these cancer cells is being targeted. And so remember, specificity is key. The place that we're getting specificity here is these viruses should only be, at least in significant quantities, taken up by these cancer cells because of a mutation in a receptor that they display that other healthy cells shouldn't have. Okay, so if all works as planned, we should have a situation where our virus is technically circulating throughout the entire body, but it's only able to really infect in significant amounts for these tumor cells. Okay. Next stage, virus starts replicating. Viral lysis of cells, meaning when the tumor cells die and the viruses burst out, all of these neoantigens, right, these novel non-human antigens that the immune system isn't used to seeing, are going to stimulate a massive immune response. So recruit antigen-presenting cells. Those antigens are going to be displayed on MHCs all over the phagocytic cells in the bladder, and this is going to hopefully get the immune system to swarm the tumor, and these CTLs, remember, cytotoxic T cells, should recognize that, and in addition to the virus, they will start killing off these tumor cells as well. Okay. And so in all of this, that strategy makes sense in and of itself. The one thing to remember is tumor cells often upregulate immune checkpoint inhibitors like PD-L1 as a way to try to shut down the immune system and prevent the attack. And so that is the explanation of why PD-L1 inhibitors are an interesting target for combination therapy, because they would probably pair well with this, using the virus to stimulate the immune system's attack, and then the PD-1 or PD-L1 inhibitor as a way to sort of take the brakes off the immune cells and make them, more ready to really go for it and kill these cells without being suppressed. All right. So obviously the most interesting question in all of this is what's going to happen with clinical trials. The science behind it makes sense. Everything lines up on like the immune system, molecular biology side of things. And so this trial it was phase 2. So we're past just strictly safety. Where phase 2 is really looking at a combination of safety and efficacy as a first step. And this CG0070, that is just the abbreviated name for the drug that we're looking at, our viral vector. Right, and this is specifically in patients that are BCG unresponsive, so non-muscle invasive, but were not responding to BCG, didn't have an effect. Right? And if we zoom in on the results, so relatively small trial, but 45 is a decent sample to work with. So when we say that there were 24, 8, 4, 6, like these numbers, this is ranking those people based on different categories of how the tumor has progressed. And the 6-month CR is telling us clinical response. So patients that had a positive clinical response in some way was 47%. Right now, 47% by itself is not a bad response rate for a chemotherapy. But remember, these were people that were already filtered as being non-responsive to the current best standard of care. Right? And so you would probably predict, although it's impossible to say for sure, that if you had started this as a first-line treatment, it probably would have given an even higher positive clinical response rate, but difficult to know for sure. Okay, and just for the sake of comparison, I tried to find some data to compare the effectiveness of this system to anything else that was in trials right now. And the only thing I could find, this CIS is one particular grade of bladder cancer scoring. The response rate there was 58%. That's the 58% that you're seeing here. CG0070 is our drug. This is a table comparing different stagings of bladder cancer. And then all of these are different therapies that are currently in trial that have data coming in. And you realize most of them are NAs because, again, there are only so many patients that we can feed into clinical trials. There's limitations on how many of these can be tested in each possible scenario. But compared to the only others that were tested, this is a monoclonal antibody therapy that only gave us 27% responsiveness. And this is another, viral vector, or at least, mRNA-based strategy that gave 40%. And so as of right now, results are somewhat limited, but as far as comparisons to other therapy goes, it seems to be giving the most positive results out of anything attempted. Okay, so the other follow-up to do here that's interesting is the checkpoint therapy combination. So in this trial, they actually were summarizing information from a lot of different possible drug combinations. And I threw this in here just to point out, how many different therapies are being tried. So we're talking about, BCG. We're talking about all sorts of other, these are monoclonal antibody treatments. This is, another sort of vaccine-esque treatment. This is another monoclonal. There are many, many, many different drugs in combination right now that are being tested. And the general pattern seems to be that combination is a good thing. That when you start with one therapy and you add more, they're not quite to the point of being additive, but you tend to get higher response rates when you combine. So let's try to combine it. The available data on specifically combining the CG0070 with anything is fairly limited. This is data that I found from a poster that was presented just last year, I believe. No actual like full-fledged publication on this, but this is the most current information that I could find. Okay, so this is our viral vector drug therapy that we just talked about. Pembrolizumab is a monoclonal antibody that's targeting the PD-1 system. And so as a quick review, remember our main drug that we're interested in is trying to stimulate the immune system, right, by delivering a bunch of novel antigens that will activate the immune system, T cells specifically. All right, but remember, cancer cells often overexpress PD-L1. Right, so here's our MHC. This would be our antigen that we hope was delivered by our viral vector, right, that we're using as our medication, and is going to be recognized by specific T cell receptors. And what we hope is T cell attacks cancer cell and kills it. Right, this entire interaction right here is effectively our stimulant. Right, that's what we expect to push our T cells towards being more aggressive and trying to take down the tumor. But this is our immune checkpoint inhibitor. So the more PD-L1 this cell makes, this is going to be our inhibitor that is decreasing the response of the T cell. So we've got this push and pull. And the logic behind all of this is, well, the stimulant by itself, probably a good idea, right? The antigens from the virus. The PD-L1 inhibitor, also probably a good idea. But what if we use them in combination? And so the hope is we deliver our virus, right, into the patient. That should target the cancer cells, lead to the production of these antigens that it will display on its MHCs. And then in addition to that, we can use this pembrolizumab, which is a PD-1 inhibitor, just an antibody that binds to and blocks that PD-1 receptor on T cells, making the immune system slightly more aggressive than it normally would be. And we hope that the end result is that this T cell now uses that aggression towards these cancer cells by killing them, which is exactly what the T cell's job is supposed to be. All right, so unfortunately, this was presented from a poster, and so it's very text heavy. It's really the only information that I could find that was available. The concept, big picture, we're taking 35 patients. Again, they are BCG unresponsive because with trials like this, patients are always going to get a crack at something that's known to work sometimes. And then the ones that don't work, we're going to move on to clinical trials to test something new. Okay, so those 35 patients were treated with our CG0070 new drug in combination with our PD-1 inhibitor, pembrolizumab, and the dosing and exact timing doesn't really matter, but they're saying that they're going to give weekly injections and they're going to administer for up to 24 months, meaning if the patient survives that long, that's the planned length of the study, right? Okay, and the grand conclusion from all of this is a response rate. They achieved 87.5%, which a couple caveats. The first is this is a relatively small sample size, but it's also not just painfully small. So 87.5%, very significant increase over the, 50-something% that we saw as our best case scenario. I think it was 40-something for the generalized, like all categories response for this drug alone. And so it seems like data are all lining up that this is a really good target for combination therapy because those PD-1 inhibitors are a perfect complement in some ways, right? This drug stimulates the immune system and sort of lures it directly to the site of the bladder. And then our PD-1 inhibitors, make the T cells more aggressive so that that response will be amplified. And in that way, they really go together incredibly well. Okay. One thing that I really couldn't take from this, they say they recruited 35 patients, and then we get, CR data for 16 of them. I'm not sure what happened to the other half of the sample size because they don't really talk about randomization like they're trying multiple therapies. It seems like all those patients got the combination. And so, it's initial data. It was presented as a poster. This is what they're willing to show everyone right now. And so hopefully, like an actual full publication will be coming out soon. And then maybe we can circle back around and revisit this when that time comes.